Hi all, my name is Sion Gadamu and I work for the Aspen Global Innovators Group. Thank you all for joining today's live Aspen Health for All conversation. These conversations are part of a larger effort housed at the aspenglobalinnovators.org that is amplifying the important work being done by leaders and innovators all over the world to address the disparities that have been amplified by COVID-19. Our aim is to focus on health equity and connect a range of experts working on the front lines of health around the world as we pivot to respond to the challenges of COVID-19. We are in search of common solutions and shared insights. And as the US reckons with the legacy of racial injustices and the continued systematic oppression of Black lives, we want to take this moment to say that we will not tolerate violence and hatred against Black communities. Our global community stands tall with local leaders, collaborators, healers, and fellows who have long been beacons in this moment and whose voices and work are critical to reshaping a healthy, equitable future for all. Today, the Aspen Global Innovators Group is excited to host a conversation with Agnes Binagwaho, former Minister of Health for Rwanda and Vice Chancellor for University of Global Health Equity, and Dr. Raj Panjabi, co-founder and CEO of Last Mile Health, on lessons they've learned about leadership in crisis and how African countries are using lessons from Ebola and how those can inform other leaders as we combat COVID-19. Please feel free to ask questions throughout the session using the Q&A box. Now I'll pass it over to our moderator, Peggy Clark, Executive Director of the Aspen Global Innovators Group.
Hello, everyone. I'm delighted that you've joined us today. This is going to be a fascinating conversation. And Sion, thank you so much for your beautiful words to begin this program for us. Let me just take a moment to introduce our remarkable speakers who are warriors for social justice, as they have been their whole lives, and dear friends and really heroines and heroes in many ways. Dr. Agnes Binagwaho is a pediatrician. She's the Vice Chancellor and Professor of Pediatrics at the University of Global Health Equity, which she helped to found. The University of Global Health Equity is the first university of its kind in the world that is focused on the questions of health equity. She's also a senior lecturer in the Pediatric Department of Global Health and Social Medicine at Harvard Medical School and an adjunct clinical professor of pediatrics at Geisel School of Medicine at Dartmouth. She also serves as a senior advisor to the Director General of the World Health Organization. She was previously the Minister of Health in Rwanda during the Ebola crisis and was able to beat that back in an incredible way. And before that was the permanent secretary in Rwanda, as well as head of the National AIDS Control Commission. Welcome, Dr. Agnes. Delighted to have you.
I'm delighted to be with you. I know Aspen, I know how you put the moment of the world and highlighting what we can do with that for social justice. Thank you for having me.
Thank you, Agnes. And let me introduce Dr. Raj Panjabi. Raj is the CEO of Last Mile Health and Assistant Professor of Medicine at Harvard Medical School and the Division of Global Health Equity at Brigham and Women's Hospital. Raj grew up in Liberia and fled Liberia's civil war with his family when he was 9 years old, becoming a refugee in the United States. He returned to Liberia as a medical student and then in 2007 co-founded Last Mile Health, a nonprofit organization working to save lives in the world's most remote communities by partnering with governments to design, scale, and sustain community health systems. I also need to say I am honored to sit on the board of Last Mile Health with Raj and to be a part of his tribe of supporters. Raj was named by Time as one of the 100 most influential people in the world and one of the 50 most influential people in healthcare, and currently serves as a Beck Visiting Social Innovator at Harvard Kennedy School of Government. Welcome, Raj. Delighted to have you with us, Raj. Oh, we've lost him. I think he'll come back, I hope. Have we lost Raj? Okay, he dropped off, but I hope he will be able to join us. Let me just keep going until Raj can jump back on. And let me start by just recognizing Sion so beautifully read the statement about the moment that we are facing of racial crisis in the US. And Dr. Agnes, can you share with us some of your thoughts from your own life about the moment we're facing in the US to start us off today. Can't hear you, Agnes.
Sorry.
And yes, we can't hear you. So hold on a second until we get your mic back on. There you go. Could you start again with your reflections?
Okay.
Thank you.
So I just want to say that the COVID-19 has highlighted the injustice that minorities, Black people, Latinos, Native Indian are facing in the US since 200 years. And they have highlighted, but they were there. And now, for example, in Louisiana, you have 70% of the COVID-related deaths that are among Black Americans, despite them making only 33% of the population. So what happened? I understand that. It's anger, it's enough is enough. But because I see in the roads, in the streets, in the newspaper, people from all race, it became now a philosophical debate. It's not only a racial debate because there are white people, Latinos, Native American who say enough is enough. I even have some message from Syria where people are fighting for their own life, say, I cannot breathe. So it is very indicative of where the US is, but also where the world is that if we don't create health systems, if we don't create social systems that are linked to the human development of all, especially focusing on the vulnerable, we will reach the unrest where the US is and is facing now.
Mm-hmm. You also, before we got on the call, Dr. Agnes, you started talking, you were giving some advice to activists who are on the streets right now, and you had some interesting thoughts about systemic change in government and how it happens.
Absolutely.
Can you share that with us?
Yeah, I understand the anger. I understand that you break everything, but I prefer you to just change the system, meaning stop breaking and go and vote. Stop breaking and become an advocate of voting and on developing the democratic tools that you have in your hands. Make sure that each and everyone can go and vote. And each and everyone drag 10 people who will vote, so that when you have the leaders you have chose, you can change the law. You can make the law more just. You can make the health system more just. You can stop making the prisons at the service of really undermining one or two race against another. So if you don't change the law, if you don't change your leaders, you will be there again in 100 years.
Thank you, Agnes. Raj, welcome back. We missed you.
Thank you. I'm sorry. I
no,
right.
It's okay. You know, the other one I did, there was actually a power outage and trees set on fire when I was trying to do one of these Zoom calls. But we're fine. We're all back together. And Raj, you know, Sion read a beautiful statement, and I asked Dr. Agnes to reflect on this moment of civil unrest and racism we're experiencing in the US. Can you add some of your reflections?
You know, I can. I think any of us who have been involved in the fight for health equity know that the fight for racial equity and racial justice is absolutely interlinked with and we know that in a couple ways. Right here in the United States, there is a disproportionately higher impact of this pandemic and so many other epidemics, whether it's complicated labor or maternal deaths. They're higher amongst African Americans. These are reflections of structural and social inequalities. But we also know this is relevant in the settings that Dr. Agnes and I have been working in settings in Africa. You know, as you know, I grew up in Liberia. My parents also, were fled the my grandparents fled British colonial rule. And so we know that this idea of supremacy of any race over another is actually at the root of so many of the histories that has shaped inequality in America, but also in settings across Africa and in Asia. So The basic idea that some humans are less or less human than others is really the root of so much of the inequities that we face in the world, including racial injustice. So we have to not be just non-racist, we have to be anti-racist, and that's why organizations like us and others are aware too that we just haven't done enough on this. Ourselves at Last Mile Health have not done enough.
Yeah. So tell me in your perspective, and Dr. Agnes, why is this pandemic also about justice and equity? Why is it more than just about a medical virus that is set loose on the world?
It's about justice and equity because the world forgot that the imperialism of some big countries are really undermining other countries that are not so powerful. I will give the example of Barbados, who had procured on time respirators for their population, and some people from one of the US states came and kidnap the respirator, give the money and say, this is the cost, we go with that. Barbados, the Minister of Health had nothing to say. This is piracy. Mm-hmm. And this is meaning because they are smaller, because they don't have the power, they can just, even if they prepare their country to face the pandemic, they just die because another country powerful hijack the good or they don't have access to good or to test. And even Raj can say how he has experience of my money as an African doesn't have the same value of the money of some white people in white states or in the Western world, because even if I can pay, I don't have access because I'm neglected, because my life doesn't matter as much.
Yeah, doesn't matter. And yes, you use this expression about the iceberg. Tell us what you're thinking about the iceberg.
Yeah, when I was telling you in the beginning that COVID has highlighted injustice that exists in the US for the last, the 200 years, just US has just celebrated a few years ago, 200 years since the beginning. And now with all those injustices, before we were just seeing the top of the iceberg, more deaths among Black Americans, more premature babies, more maternal deaths, more drug addicts, more people without housing. And now we just see the systemic of the system of that. And that means the police system, the structural violence that is so intense, the judiciary system, the police system, all this is unveiled by COVID, and they stop to be the top of the iceberg. You can see the entire iceberg, and you can see why systemic changes are needed. And this is linked to the social determinant of health. You will not get health if you don't solve all the problems that are linked to the social determinant of health.
So let's turn to talk about Ebola. And you both lived through the Ebola crisis, were at the forefront of beating back the crisis in Rwanda and Liberia. So do you believe that we as a world learned lessons from Ebola that are being utilized today? And what are the most critical lessons from the Ebola crisis that we can implement to the COVID pandemic? Raj, let me turn to you. Oh, Raj, you're on mute.
I think there are a couple of lessons. One is on the problem side, and the other is on the solution side. So on the problem side, we know that Ebola taught us, whether it's vaccines, it's testing, or it's treatment, if we let things go without correction, without any effort, those that are rich and powerful, the powerful nations and the rich within those nations will get access to those, and many that are poorer within those nations or the poorer nations of the world will be excluded from that. You know, it's almost, and I don't use this term lightly, like a viral apartheid that we faced during Ebola. Just look at the case fatality rate, the death rate amongst those who were evacuated from West Africa. largely expatriates who were on the front lines, who had come to serve in our crisis, which we were all grateful for. They had the same virus, Ebola virus, but the majority of them, if not all of them, survived. 100% of them survived. Whereas the death rate in Liberia, in the places where we were working to support the Ministry of Health, the death rate was as high as 60% from the same disease, same biology of the human body. So one lesson and takeaway is that if we want to correct for that, we've got to first acknowledge that there is a huge inequality, and we're seeing it again here in COVID-19. While Africa has fewer cases, as of now, we think it's just behind the curve. There's over 130,000 confirmed cases. We know in settings like Liberia with weaker health systems, the case fatality rate, the death rate amongst known COVID-19 cases is 10%, whereas in other settings it's as low as 3% or less amongst known cases. So to me, that's lesson one: is that we have to recognize that pandemics expose inequalities in healthcare systems, and we've got to correct those. The second thing we learned is that the best emergency system in response to a pandemic or an epidemic may not be an emergency system per se, but an everyday healthcare system that can be surged during a crisis. And the more proximal that healthcare system is to communities at risk, the better chance we have at succeeding to respond in an equitable fashion. So one key aspect of a health system: you need labs, you need hospitals, you need, in this case, oxygen therapy, you need ventilators. One of the other aspects that's needed is to ensure that community health workers, members of the communities most affected, become part of the medical team. So in Liberia, in Malawi, in Ethiopia, Uganda, some of the governments we're working with in various ways, we're seeing those countries hire and train or retrain, if they already had, thousands of community health workers who are not waiting for patients to come to them, but are going door to door to find the sick and get them into care, isolate those that are needed to be isolated, ensure that their testing is happening. And just one statistic I'll give you before turning back over is you're seeing the results. You know, I sat here in a COVID clinic in Boston 2 weeks ago caring for patients. We cared for 67 patients who needed testing, but all of them had to pick up the phone, call their doctors, and then get screened and then come to get tested, which means we were missing many patients who are out in the community. Outbreaks start and stop in the community. South Africa, as an example, or Ethiopia as another example of a country that's doing it differently, is saying, we're going to hire and train the neighbors of those patients and those at risk. We're going to make them community health workers and ask them to screen patients door to door with the right protective gear. South Africa has screened in just the first couple of months 11 million South Africans, 20% of the South African population, which has increased equitable access to testing, which then improves access to treatment and care.
So, Raj, what is the reason why these basic ingredients of using community health workers, for example, and contact tracing have been so slow to be adopted in the US? And in the places where we are seeing it now, for example, Partners in Health work in Boston and others, I understand community health workers are calling people on the phone rather than going door to door. What's your sense of what's the state of play in terms of contact tracing in the US context? Because examples is fascinating.
Right. Yeah. And I'm just so grateful to our friends at Partners in Health and the governor of Massachusetts here. And a number of other states have now started to invest in this. But the reason it has not been there before is that public health departments in this country, where a lot of the work of contact tracing or screening, whether it's by phone or door to door, is actually done by those local and state public health departments. But we've, since the recession here about 11 years ago, have dramatically defunded these public health departments. So when the work of contact tracing was necessary at the beginning of the outbreaks in every state, when there was a manageable caseload, these departments didn't have the staffing, the people power they needed to go and actually make those phone calls or go to door to door, even consider the idea of going door to door to equip and train workers to do it. So we now have had a peak. We've had over 100,000 lost American lives. And the other challenge, of course, is that we've designed our healthcare systems in the US so that patients have to come to the point of care. We have not designed a system where we bring the point of care to the patient. And so I think now what we're starting to do in state after state, and what we're going to have to do, is to train up a national health force, a workforce of community health workers that start with helping with contact tracing. And I think eventually we'll need to continue to do the work of screening and testing and supporting that. But I hope that we will take this moment, as countries like Liberia had during the Ebola epidemic, this painful moment, and say, can we double down an investment that could actually make a long-term community health workforce present? And you're seeing that coming up in the Congress. Senators Gillibrand and Bennett have introduced a bill that I hope will get bipartisan support and cross-partisan support. That's called the Health Force Bill. And the idea is to train and employ up to 1 million unemployed Americans, because there are too many now that are unemployed from this crisis, to be part of a community health workforce. And some of that funding, they're asking for $100 billion in the next coronavirus relief package, ought to be going to local community-based organizations that are already working with community health workers to help scale those organizations up. So I hope those on the call will take it as an action point to, if you have a congressional leader that you're in touch with, to pick up the phone and call them and ask them to support bills like this one.
That's great, Raj. That's really helpful. Gillibrand and Bennett. And we'll follow up with details. And yes, let me turn to you. What do you see as the key lessons from Ebola for the COVID pandemic? And you've talked in particular, you mentioned a few things, trust as critical. Tell me your thoughts on this.
Yes, because Ebola was a mess also in many countries because there was a distrust of the population to their leaders. In the US, there is a mess for COVID because there is a distrust to what happened, and also because we create a distrust to science. What is the basic of healthcare? And so the lesson of Ebola is that if you don't have trust, people don't believe what you say. People doesn't participate in a dialogue, in create the system at community level, but all along the system to do what it matters for them to stay alive and healthy. They don't go in isolation. They stay in community for Ebola and they contaminate others and create death also. Here, people deny COVID. Just say, I don't wear a mask because I don't need to be protected. I don't need to protect others. You don't create trust. You don't create solidarity. People infected are dying more if they are vulnerable. Healthy people are in their very, people with money are safe where they are because they are not in contact with the virus, so they don't care. So we need to teach people who are vulnerable, who are poor, to trust science. But the government needs to create trust if they want to be followed when they give directives to the people, and also create health system that respect your dignity.
Beautiful, thank you. And yes, let's turn. We have some wonderful questions coming in from the listeners, and thank you all for joining us. The first one is really around leadership. What kinds of leadership from Liberia and Rwanda was the most powerful for driving real change that benefited all people? Who and what made a difference?
Accountability.
Accountability. Okay.
Accountability. I just want to say that the previous Minister of Health before this one, who was sacked around accountability vis-a-vis COVID, about saying something wrong about testing. So that will make the people accountable of what they say, what they do, what they should do because they're in position and pay for. It's key. So the leadership accountability, and also a leadership that is focused on the people the most in need, not for the people like me who are the well-off, can always find our way to find the solution if I'm sick.
What do you think, Raj? What do you think was the key leadership element in the Liberia
I
situation?
think accountability is spot on, and I would add to that humility. You know, Madam President Sirleaf, Ellen Johnson Sirleaf, who was our president during the time, had a very challenging experience where she had asked, at the height of the epidemic, we've been told as many as more than 1 million people would be infected across Liberia and the 2 countries near it. And in that moment, you know, businesses were shutting down, the economy was going into lockdown, airlines were cutting off their travel to the country. You know, it's not 2 very different viruses, COVID and Ebola, but similar human responses. She responded initially by quarantining one of the communities in Monrovia, the poorest community, West Point.
Mhm.
And it was quarantined with soldiers, and that increased mistrust. It resulted, unfortunately and tragically, because of the protesting, in the loss of a little boy's, teenage boy's life, because he was shot. She then immediately the next day walked into that community, met the family, apologized with humility for the mistake she had made, and committed to, in fact, have a more proximal community-based response. And it was after that, then the communities were not seen as the enemy of the state, to be repressed and suppressed, but rather to work with the state, to work with the country on a more humane response. In fact, they were employed to be part of the workforce. And over the following months, 10,000 community members, caregivers of people with Ebola, other at-risk communities, joined arms with doctors and nurses that were government doctors and nurses to go to door, find the sick, get them into care. And, you know, ultimately, I think the lesson learned from humility was when these epidemics threaten to bring humanity to its knees, we've got to join together, not pit against each other. And when we do that, we have a better chance.
That's great.
What I can add also, Peggy,
Please.
about accountability is that when people die because you are a bad leader, you should be accountable to that. There are more people die by leaders that are mismanaging their people than people die by tyrants that are killing them. A tyrant go to tribunal, international tribunal court. We should do the same for the health sector. A life is a life.
Absolutely. So I wonder if you could also say just a couple words about leadership in a time of crisis. One of the things I've been thinking so much is about how people need to just step in. And that's what people are doing on the streets in the United States right now. And you both just step in no matter what. Dr. Agnes, I remember a moment in the film Bending the Arc, which is about partners in health, where you hear that Ebola is at the borders of Rwanda, and you just set up a phone bank. So what would you say to people who are listening about how they can be leaders in this moment?
Raj, to you.
With you.
You know, I would first of all say, remember that these crises are, and who they affect and who they don't, are reflections of the strengths and weaknesses in our society. And those strengths and weaknesses, those fault lines, have histories. And if you look back in the history of justice and equity, whether it's the civil rights movement in the United States, the anti-colonial movement in India, and so many others, we will see time and time again that power has never been granted easily by those who possess it. It must be demanded by those from whom it's been taken. And that can be done non-violently through protest. It can be done through pragmatic action by ensuring equitable health services are delivered to the marginalized. But one way or another, we're confronting power, and we have to be just as technically smart as we are. Yes, that's part of the solution, the digital apps and the innovation, the health systems innovations, but ultimately also requires us to be courageous and brave as well at the same time to confront that injustice.
Thank you. Thank you. Unfortunately, we've come to the end of our webinar. And Dr. Agnes, I want to give you the last word so that since we're so lucky to have you with us, before I share with the team, with the listeners, how they can help this work you're doing.
So I just want to add on the role of each and everyone. Such a crisis, global crisis, need the support, the action, and the intervention of each and everyone. It's not only the leaders and the health workers, it's a multi-sectorial problem, and everybody should feel the duty to jump in and do what they can do.
Mhm. Beautiful. Thank you. Thank you, Dr. Agnes. And we encourage everyone who's taking part in this to support University of Global Health Equity, which is a brave and bold and wonderful idea that Dr. Agnes is supporting, and also to support Last Mile Health's work. There's specific information that and work that they're doing in relation to COVID. So we would love for you to join them on this journey. They are the best. And I really want to thank you, Dr. Agnes, and thank you, Raj, for your incredible work and for all that you give to the world and to all of us.
Thank you, Peggy. Thank you, Dr. Agnes.
Thank you, both of you, to have me with you. It was a great conversation, to be continued.
Wonderful. Thank you, everyone, for joining us today. And you can take action by going to the websites listed on the slide right in front of you, and we will also be sending you a newsletter with more details. Thank you all.